Okay. All right. So anterior forearm. Oh, come on, show up chat. Sorry. Okay, good. When it comes to the anterior forearm, the predominant bones are your radius and your ulna. And you can see how your radius is more lateral versus your ulna is more superficial. So because of that, you'll have structures where we might say the radial side or the ulnar side. And that's the shorthand for, is it more lateral or is it more medial? You'll also see things that have like radial ulnar in the name. So just trying to associate those things together. For our radius and our ulna, you can see this is an anterior view, this is a posterior view. You can see how your olecranon, that is our bone structure, that is our elbow, is articulating, and it's on the ulna and it's articulating with our humerus. So when it comes to articulation of these structures, remember that the humerus articulates with the ulna articulates with the radius both proximally and distally, and then the radius articulates with your carpal bones, your wrist bones. Okay. So again, here's our olecranon, the actual elbow bone. Here's our trochlear notch. That's like the cut out, scooped out area that actually articulates with the trochlea of the humerus. So that's how you're able to hinge like your elbow. In between your radius and your ulna is our interosseous membrane. You'll hear interosseous associated with blood supply and with nerves because they're all like related in this area. The interosseous membrane is connecting these two bones together, but also giving them the flexibility of supination and pronation for actions of different muscles that are happening with these bones. And also note that both the radius and the ulna have a styloid process. So when you see styloid process, think of a little area that's jutting out at like the end of a bone. So you can see here's ulna and here's the radial one. When it comes to the ulnar, like the cellular process of the ulnar, I think about how you can get an avulsion fracture of this particular part of the bone, and avulsion fractures when you rip off that part of the bone. You can get it with a Colles fracture. So it can be, and remember our Colles fracture is the fracture of the distal 2 centimeters of the radius. So you can get the Colles fracture of your radius along with avulsion of your styloid process of your ulna. Oh, speaking of, so Colles versus Smith. Colles is the most common of the two, and it's actually one of the most common fractures of your upper limb. So when you have a Colles fracture, this is one of the fractures you can get when you fall on your outstretched hand. That's also known as like a fouche injury. So falling on our outstretched hand. You can get a lot of different fractures. This is one of the more common ones. And for Colles, you end up with what's called the dinner fork deformity. So notice how for this particular patient, so she fell, the force of the fall is pushing in this direction, which because of anatomical position, it's actually pushing posteriorly. Remember, our anatomical position is on the dorsal side of our hand. So because it's pushing posteriorly, you actually end up with posterior displacement of that broken piece of your radius. So this is the posterior displacement here. And then comparing, here's our dinner fork, and then here's our hand and our wrist. You can see how you get this shape that's similar to the shape of a dinner fork because of the fracture. So that's why they call it the dinner fork deformity. When it comes to your Smith fracture, it is pretty much just the reverse. How for a patient with a Smith fracture, the force of their fall or the force of the break causes an anterior dislocation of that distal portion. And then, yeah, that's just like the biggest thing is knowing that Colles fracture is posterior displacement of the distal fragment versus Colles is anterior displacement. Excuse me, Smith is called, repeat. Colles is posterior displacement. Smith is anterior displacement. Colles is more common. Coles, Colles, however you want to pronounce it. Okay. So, muscles of your anterior forearm. And this is when I'm going to start switching back and forth. When I learn these in pieces because it's a lot of information to chunk. It's a lot of muscles. So I'm going to try and break it down in ways that's going to help you chunk it to remember it. All right. So when I learn the anterior forearm muscles, I learn them in layers because you have a superficial layer, an intermediate layer, and a deep layer. For your superficial layer, it's 4 muscles. Your intermediate layer is only 1 muscle, and then your deep layer is 3 muscles. So I remember it's 4 minus 1 equals 3 for the number of muscles in each layer. Once again, this is a great Netter picture where it shows you in the red is the origin for the muscle versus the blue is insertion. So for your superficial layer, recall that we have 4 muscles. The mnemonic I used for remembering those 4 muscles is pass, fail, pass, fail. Dr. Preddy has really good videos to help you memorize the muscles in the anterior forearm, and I believe the links to those videos are at the beginning of this PowerPoint, and this PowerPoint should be up in your class drive for reference. So the 4 muscles of your superficial layer, you have your pronator teres, which is right here, which it tells you in the name that it's going to pronate. You have your flexor carpi radialis, which you can see right here. So literally it flexes the carpal bones on the radial side of your wrist. So flexor carpi radialis, which remember radial is more lateral versus ulnar is more medial. Your palmaris longus, which it's here and it's really long and it ends up ending as a retinaculum in your wrist going into your hand. So your palmar aponeurosis. This is your palmaris longus. And of the muscles in this layer, the palmaris longus is actually sometimes not found in humans. Some people don't have them. Most commonly, the people that do not have them, I believe, are white women, but you can either see or feel your palmaris longus by touching your thumb to your pinky finger and then flexing your wrist up, and you'll feel it there, like in the middle of your hand. So touch your thumb to your pinky finger, and then flex your wrist and put your thumb in like the middle of your wrist, and you'll be able to feel your palmaris longus tendon. And then finally of these 4 is your flexor carpi ulnaris. Again, we are flexing the carpal bones on the ulnar side. So you can see here, flexor carpi ulnaris going in, and it's going to insert on the carpal bones that are on the ulnar side of your wrist. This is another picture here. And of course, I put in this chart because some people really love charts. When it comes to innervation of the muscles of the anterior forearm, it is mostly median nerve with the exception of 1.5 muscles. So the 1 muscle is flexor carpi ulnaris. So it makes sense that the ulnar nerve is gonna innervate a muscle that's named flexor carpi ulnaris. So thankfully that one's nice and intuitive. The other 3 muscles that are in this layer, they're all innervated by median nerve. Okay. So once again, showing you the insertions of the tendons of these different muscles. Here's your flexor carpi radialis on the radial side of your wrist, inserting on those carpal bones, versus flexor carpi ulnaris, inserting on the ulnar side of your wrist on those bones. And then your palmaris longus going all the way down and then ending as the palmar aponeurosis. Oh yeah, and this is a funny trick that helped me like remember stuff. So you actually, if you bend your middle finger to your palm, you can't completely straighten out. Your ring finger is physically impossible because you have insertion of the palmar aponeurosis on the 2 metacarpals, on metacarpals 3 and 4. So if you try to, you can maybe get to about like 75, but you can't get the full straightening out unless you physically force your fingers that way. And that's just one of the quirky little things about the tendinous insertions of these muscles. For me, learning about the quirks just sort of helped me to remember the muscles and stuff. So, okay. So our intermediate layer, remember it's only one muscle, and it's your flexor digitorum superficialis. So you're flexing your digits, and it's the superficialis, because you can see here, you can see it's coming in, and when the tendons are inserting, they actually split in half. So they split in half to insert on like the middle phalanges here. Insert, 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 insert. And that's because a different muscle's tendons go underneath the tendons of flexor digitorum superficialis to insert even farther along on the phalanges. But yeah, so flexor digitorum superficialis coming down and inserting on your middle phalanges. So splitting in half and then inserting on each one of the middle phalanxes. Okay, and now your deep layer. So for your deep layer, you have your pronator quadratus, your flexor pollicis longus, and your flexor digitorum profundus. So you can see here, this is your flexor pollicis longus. So when you see pollicis, think thumb. So flexing the thumb, and it's longus because it has a long tendon. When you see a longus, there's usually a brevis, and there is a flexor pollicis brevis that's in the hand itself. So our flexor pollicis longus coming down and inserting on the distal phalanx of the thumb. Versus your pronator quadratus is this rectangular muscle here at your wrist. I used to think of it as a muscle bracelet. But yeah, it tells you again in the name pronator. Oh, so we know that part of its action is going to be to pronate. So pronator quadratus muscle right here, your like muscle bracelet. And then the more interesting muscle, your flexor digitorum profundus. So I mentioned before how your flexor digitorum profundus, the tendons go through the split of superficialis to insert at the most distal phalanx. Well, flexor digitorum profundus, because it does that, that's the muscle that's actually bending the very tips of your fingers. So flexion at the tips of your fingers. So flexion at the DIP, which we'll get into DIP versus PIP. Your flexor digitorum profundus, the way that I remember that it had a different innervation was that it's profundus, it's profound, so it has to be more complicated. Flexor digitorum profundus has dual innervation, so you have insertion on all 4 of these digits here. And you have a median side versus an ulnar side. So the ulnar side is the 2 tendons of your 4th and 5th digit, so your ring and your pinky finger. The muscle that has those 2 tendons, that one's innervated by ulnar, versus the tendons of digits 2 and 3, that part of the muscle is innervated by median. So flexor digitorum profundus is half innervated by median, half innervated by ulnar nerve. So that's how we end up with 1.5 muscles in the anterior forearm being innervated by ulnar nerve. This is the half, is the ulnar side of flexor digitorum profundus. Okay. So again, with the anterior forearm, innervation of the muscles, it's mostly median, except for the 1.5. So flexor carpi ulnaris, ulnar's in the name, and then 1/2 of the flexor digitorum profundus, the ulnar half, which versus the other half is innervated by median nerve. Okay. All right, and he also has very good charts in his PowerPoints. Okay. And then just showing you as it's coming down, like median nerve coming down to innervate and ulnar nerve coming down to innervate. Okay, so now clinical correlations. injury to the posterior cord of the brachial plexus caused by pressure of the crosspiece of your crutch, paralysis of the arm called crutch palsy, loss of function of extensors of the arm, forearm, and hand, and produces wrist strap. Okay, so the thing with this is that for you to best understand this, he needed to tell you about the posterior forearm. Did he have posterior forearm? Oh, he did. Okay, so I'll go into posterior forearm muscles. There's also a lot of those. Sorry, folks. Okay. So your posterior forearm muscles, there's 12 of them. I learned them in 2 layers, with each layer having 6 muscles. And then the mnemonic that me and my friends used, which I think is also from Preddy, is in his videos, because it's 2 of them, but I think they're combined, there may be like 20 minutes. So 15 to 20 minutes giving you good practice, good mnemonics to learn the muscles of the anterior and posterior forearm, as well as the hand. He goes into like hand stuff too. So layer 1 is radial, digitorum, digiti ulnaris, versus layer 2 is a supin brevis sandwich, please. So we'll get into the specifics in just a sec. So when we talk about radial, digitorum, digiti ulnaris, we're talking about the more superficial layer of muscles in the posterior forearm. If you look at well, here, I'll just show you. They're all on YouTube. This is slide 36. If you go to slide 2 of this deck, I actually put in the links directly for Preddy's videos, as well as like some more nerve stuff and blood stuff. So these are the 2 Preddy videos I was talking about. Okay. No problem. Okay. So radial is brachial radialis, extensor carpi radialis longus, and extensor carpi radialis brevis. So here's your brachial radialis, which is telling you about itself in its name. Brachio for the arm, and then radialis is on the lateral side of your upper limb and inserting down below, like closer to like your wrist on the radius, the bone. Your extensor carpi radialis longus and brevis, once again, one's longer, one's shorter. They both are helping to extend your carpal bones on the radial side of your upper limb. So you can see, there we go, extensor carpi radialis longus, and then brevis. And usually when there's a longus and brevis, usually but not always, it means that either the muscle itself is longer or the tendon is longer. So for this one, you can see how longus has a bigger muscle belly, but the tendons are about the same. But yeah, here's longus, here's brevis. So that's your radial. And then digitorum is your extensor digitorum. So you can see how extensor digitorum is this muscle here, and it's traveling all the way down and inserting onto digits 2 through 5. So 2, 3, 4, and 5. And then digiti is referring to extensor digiti minimi. Remember, when you see digiti minimi, think little finger. So this is a muscle that is specific just to the little finger to help it with extension. So extensor digiti minimi. And then finally, ulnaris, your extensor carpi ulnaris. And since there's no longus or brevis there, you know that there's just one of them. So it's extension of the carpal bones on the ulnar side here. So this is the superficial layer of your posterior forearm. Versus the deep layer, used more of a funny mnemonic because the muscles have like not as logical names. So Anconius, so a supin brevis sandwich, please. And when you say please, you're supposed to extend your first digit. So as if you're trying to get somebody's like attention at a lunch counter. We'll talk about why in a second. So the A is for anconeus. You can see anconeus right here, this triangular shaped muscle. And then sup is for supinator, which supinator is deeper, so you can't really see it on this picture. I have to look around and find you guys a picture of supinator, but it's deep to this. And then, so the brevis sandwich they're talking about is the fact that you have extensor pollicis brevis is in the middle of this longest sandwich right here. So you have abductor pollicis longus and extensor pollicis longus. So notice how lots of pollicis, two longus in between a brevis, and then you have the abductor and then the two extensors. So abductor pollicis longus, extensor pollicis brevis, and then extensor pollicis longus. And these three structures together create what's called the anatomical snuff box, which we'll see a better picture of on the next slide. And then finally, extensor indicus, literally extending your index finger. So anatomical snuff box, you can see here's the three tendons and they're all going and inserting onto your thumb. Y'all have pollicis in their names, so you know they have to do with the thumb. And the anatomical snuff box is just sort of this indentation that's in here that's made by the tendons of the muscles. And some people, if you're like super fit, you splay out your hand with your thumb out, so completely like tensed, and you can see the divot of where those tendons are. And it's called the anatomical snuff box because that's referring to the fact that like back during the 20s and stuff like that, snuff is like a euphemism for cocaine. So the anatomical snuff box would be, they would put snuff in like that divot, and you can actually feel it even if you're not athletic. You can feel where the anatomical snuff box was. They would put snuff in there and then they would snort it. So it's called the anatomical snuff box because it's like, oh, there's a spot right on my hand that helps me do this. Granted, this was back in like the 20s, so, you know, more accepted, but they still, like the terminology still lasts to this day. And the reason why we care about the anatomical snuff box, a couple of things. Your radial artery passes through it. So it's very, like, that's one of the spots that you can go and you can feel for a person's pulse. The floor of your anatomical snuff box is a scaphoid bone. And we mentioned before how the scaphoid bone is the most commonly fractured bone in your wrist. So your wrist bones, your carpal bones. So it's there. So there's just structures that are passing through that are important. So we remember, like we still hold on to that terminology for the anatomical snuff box. And then, oh, here we go. Here's a picture that's has some of the muscles cut away so you can see supinator is deeper. All of that. And all of these posterior forearm muscles are innervated by radial nerve. So it goes with the whole, like if it's in the posterior upper limb, most likely it's radial nerve. And then I just had a note on supination versus pronation, how to achieve pronation, you actually have to cross over the radius to the ulna. So you see the two bones are actually crossed over each other, and obviously the interosseous membrane that's in between them is helping them do this action. But it's your pronator teres with the quadratus that work opposite of your supinator, and they're just going back and forth in each other, having opposite actions in order to make this movement happen, where you can supinate and then or pronate your upper limb. Okay. And back to his clinical correlations. So now, when talking about crutch palsy, because you've put pressure on your radial nerve as it's trying to go and innervate these muscles, that's how you can end up with crutch palsy, because that cross piece pushing up against the nerves in your armpit can lead to loss of innervation, like temporary loss of innervation of the extensors of the arm and the forearm and the hand. And in doing so, you're going to produce wrist drop. And whenever you see wrist drop, think radial nerve damage. Injury to the radial nerve. So we already talked about this previously, but you can get injury to the radial nerve when you have a mid-shaft fracture of the humerus. And in doing so, you could possibly also injure your profunda brachii, also known as your deep brachial artery. You'll have loss of function of the extensors of the forearm, the hand, the metacarpals, and the phalanges. When you lose radial nerve, you lose extension, because that's like the action that happens on the from the muscles of the posterior upper limb is extension, and you'll end up with wrist drop. So when you have injury to the musculocutaneous nerve, recall that the musculocutaneous nerve innervates the anterior compartment of the proximal arm. So those three muscles are your biceps brachii, your coracobrachialis, and your brachialis muscles. You'll end up with weakness of supination because your biceps brachii, its main action is supination, but it also flexes along with brachialis. So you'll end up with weakness of flexion of your forearm, as well as loss of sensation on the lateral side of your forearm, because recall that the terminal branch of your musculocutaneous nerve is the lateral antebrachial cutaneous nerve. So not only do you have weakness of these actions because you've lost that innervation because of injury to that nerve, you'll also have loss of sensation on the lateral aspect of your forearm. Injury to your median nerve, again, we went over this, how a supracondylar fracture, which just means above the epicondyles of the humerus. So supracondylar fracture can cause damage to your median nerve, as well as your brachial artery, because it's also in the area. It can also cause compression of your, caused by a supracondylar fracture of humerus, or, oh yes, where you can also damage the median nerve. So more proximally is a supracondylar fracture. Distally, compression of the median nerve and the carpal tunnel can cause injury. That's how you end up with carpal tunnel syndrome. So you'll have loss of pronation if it's more proximal where the injury is, versus you'll have loss of opposition of the thumb and flexion of the lateral to interphalangeal joints if it's in the carpal tunnel. And you can end up with APAN, or I learned it as Benedictine attitude. So APAN is that flattening of your thenar eminence, versus Benedictine attitude is a person who you ask them to make a fist, and when they make a fist, they can only flex their fourth and fifth digits. They can't flex their first three digits. Is because they've lost median nerve. Because recall that median nerve is going to get you your lumbricals. It's going to basically just messes up the first three digits. Versus injury to your ulnar nerve, you can get this by a fracture of the medial epicondyle, and it can result in claw hand. You can also injure your ulnar nerve in Gunyon's canal. So a fracture of the hook of hamate or compression of the ulnar nerve as it passes through Gunyon's canal can also cause injury. But yeah, he didn't mention that there. I know Dr. Austin has in the past though. But yeah, so he wants you to know about the fracture of the medial epicondyle causing claw hand. So ulnar nerve damage, think claw hand, because you've lost the intrinsic muscles of the hand. And remember, the muscles in the hand are mostly innervated by ulnar nerve, except for the 1/2 loaf that's innervated by median nerve. So 1/2 loaf standing for your first and second lumbricals, as well as the muscles of your thenar eminence, your OAF, your opponens, abductor, and flexor pollicis. Okay, so now he's talking about features of the hands, and I'm going to bounce in between this slide and a slide that has, yeah, because it doesn't show any pictures. Okay, I'm going to bounce in between these slides and slides with pictures. Give me 1 second. No, it's going into the bones. He was talking about, there we go. Okay. There. All right. So your extensor retinaculum is a thickening of the antebrachial fascia on the back of the wrist, versus your palmar aponeurosis is triangular fibrous layer overlying the tendons. That's protecting the superficial palmar arterial arch, palmar digital nerves, and long flexor tendons. It is coming off of your palmaris longus, like it's an extension of your palmaris longus. So basically, the palmaris longus tendon then flows into becoming the palmar aponeurosis. At least that's what I learned. Your palmar carpal ligament, thickening of the deep antebrachial fascia at the wrist, covering the tendons of the flexor muscles, median nerve, and ulnar artery and nerve. Okay. Your flexor retinaculum. Now this one you need to know because it forms the roof of your carpal tunnel. It's an origin for muscles of your thenar eminence, so those three muscles innervated by median nerve that are manipulating your thumb in your hand, crossed superficially by the ulnar nerve, ulnar artery, palmaris longus tendon, and palmar cutaneous branch of the median nerve. And then your carpal tunnel, formed anteriorly by the flexor retinaculum and posterior by the carpal bones. And through your carpal tunnel, you have one nerve, 9 tendons that pass through. It's your median nerve, and then the tendons of your flexor pollicis longus, your flexor digitorum profundus, and your flexor digitorum superficialis muscles. Okay. And then tendons of the flexor and extensor digitorum muscles. Flexor digitorum superficialis tendon splits into two. So we already talked about this when you saw like the insertions of the muscles onto the phalanges, how the superficialis splits so that profundus can go through and then insert. And then we talked about your anatomical snuff box. All right. So just to show some of the things instead of just reading. Here's your carpal tunnel. You can see your flexor retinaculum as the roof, and then the 9 tendons and 1 nerve going through. And then you can see over top how ulnar artery and nerve pass above, so they do not actually go into the carpal tunnel. And then again, here's the floor, here's your carpal bones, the retinaculum is your roof, here's your median nerve, here's your flexor pollicis longus tendon. And then when it comes to the tendons of the other 2 muscles that pass through, you do need to learn the orientation, how flexor digitorum profundus actually goes through flat. So this is the tendon that goes to digit 2, digit 3, digit 4, and digit 5, as opposed to your flexor digitorum superficialis, the tendons are stacked. So tendon for digit 3, tendon for digit 4, tendon for digit 2, tendon for digit 5. So it's 34 over 25. Okay. All right, other clinical correlations. So Dupuytren's contracture. Dupuytren's contracture is a progressive thickening, shortening, and fibrosing of your palmar fascia, especially the palmar aponeurosis, that produces a flexion deformity of the fingers in which the fingers are pulled toward the palm. And I have a picture of Dupuytren's contracture, because I've said this before, how when I learn, I have to see pictures in order for me to understand it best. Where are you? There you are. So this is a picture of a hand of a patient who has Dupuytren's contracture. So the thing about Dupuytren's contracture is it can make you think that the person has some sort of damage to a nerve, but it's not. It is literally just thickening and fibrosing of fascia. And the way that you treat it is usually surgical. So this will be like a slow process of the thickening and the fingers being pulled slowly towards the palm. They don't really know why this happens. They hypothesize that it's like hereditary. Excuse me. But what ends up happening is that they will eventually have surgery and there'll be excision of the fibrotic parts, and then you sew it back up. So basically you go in, you cut it, you take out that fibrosis, you try and sew it back together loosely, so they don't have like that pull in their hands. And hopefully that's that, and they won't have to have any further surgeries, but they might. Oh, let me go back. What would be a way to distinguish between this and medium nerve damage? Okay, so at rest, their hand will look like this. Like they can't actually straighten out their fourth and fifth digits. Rheumatoid arthritis is more about joint damage. Dupuytren's contracture is about fibrosis of the tissue. So rheumatoid arthritis is going to be in the knuckle, and not in the knuckles, and like the joints. And actually, I have a picture of that, so you'll see that in just a second. Yeah, Dupuytren's contracture is about the fascia thickening and shortening. So for these patients, they come in and their fingers have slowly like progressed towards their palm. So you would get that in a history. If you ask them to make a fist, they're still going to make a fist. So that's how you can distinguish it from median nerve. For Dupuytren's contracture, they would still be able to close their hand. It's just that when they open it, the fourth and fifth digit couldn't open all the way because that shortening and thickening of the fascia there. Okay. So yeah, that's Dupuytren's contracture. So this is what a hand with RA looks like. This is like this hyperextension and flexions of your joints. Like that is what RA causes, as opposed to with Dupuytren's, how it's shortening and getting the fingers to be closer and they can't really move that much. Okay. And then his next one was Volkmann contracture. Okay, I've never heard of this one. Ischemic muscular contracture of the fingers and sometimes wrists resulting from ischemic necrosis of the forearm flexor muscles. Oh, that makes sense. Yeah, so you would have some sort of, yeah, for ischemic necrosis of your forearm flexor muscles, that means you would have lost blood supply to them. So it would have to be some sort of blockage. And then as those muscles die, I guess the tendons would start pulling because the muscle is getting smaller. That's the only thing I can think of. For carpal tunnel syndrome, that's compression of your median nerve in your carpal tunnel. And you can get it from either inflammation or, I mean, especially since we're a society that types a lot, from daily compression of the median nerve in your carpal tunnel from like typing and repetitive motion things. It can lead to pain and paresthesias. You can also get carpal tunnel while you're pregnant, which sucks. So yeah, that's just one of the things that can happen. And that's just because when you're pregnant, you're in a state that's more likely to be like inflammatory, like a higher inflammation state. But yeah, so knowing that it's compression, inflammation in the carpal tunnel leading to carpal tunnel syndrome, and it's your median nerve, and it leads to pain and paresthesias. And the first line treatment is usually like putting them in a wrist, like a little wrist sling, that thingy that you buy at like CVS, just to keep their wrist flat, and try and put some like soft padding, just something like that makes it so you're not putting that pressure on the carpal tunnel, so you're not putting that pressure on the median nerve. Versus handlebar neuropathy, this is for people who do long bicycle rides. So you're putting pressure on the hook of hamate, which again, your ulnar nerve runs through the hook of hamate. So you can end up with sensory loss on the medial side of your hand, so your fourth and fifth digit, as well as weakness in intrinsic muscles of your hand, because again, ulnar nerve does that sensory innervation in your hand. And then we go into arteries. Okay. Me just 1 second. Is there anything in here that was not really? Okay. Yeah, I just want to make sure there weren't any other clinical correlations that were really important before I skip over to hand stuff, because that's more hand clinical correlations. Okay. All right, so talking about the anastomosis of your radial and ulnar arteries, that's pretty much like your hand. Your hand represents an anastomosis of your radial and ulnar arteries. So when those two arteries bifurcated off of your brachial artery, they continue going down with their associated bone. And then they both give blood supply to the hand. And the hand is a mess of arteries. It's another spider web of arteries all around your digits trying to get blood supply to all of them. The two biggest anastomoses that we had to learn about were the superficial and the deep carpal branches, which I like the picture that I have because it's from Gray's. There we go. So you can see how it talks about how mainly, so both the ulnar and radial arteries provide blood to your superficial and deep palmar arches. So together they represent an anastomosis of those two major arteries. In the way that Gray's describes it, they talk about how the blood supply in this area is mainly from radial and the blood supply in this area is mainly from ulnar, but these are two anastomoses between the two arteries. Things of note in this area where it's listed as mainly radial is your princeps pollicis artery, which is a branch off of radial. So you can see this is your radial artery, it keeps going, and then you have a branch that goes to give blood supply to the thumb. That's your princeps pollicis. But then you also have a branch that goes and gives blood supply to this lateral side of your index finger. That's radialis indicus. So those two are special. But still, you see how radial artery is contributing to this deep palmar arch, as well as the superficial arch, and how ulnar artery is contributing to both the deep and the superficial arches. So they're anastomosing in the hand. These two arches link up again. So you see how there's a branch this branch is coming off of the superficial, and then branches coming off of the deep. They actually link up again at the ends of where your metacarpals are, and then split to give blood supply to these sides of each of your digits. So all of this blood is just mixing. So that's the anastomosis between like your radial and ulnar arteries, is these two arches, your superficial and deep palmar arches, as well as on the backside of the hand too, I believe. Hold on. Yeah. So your dorsal carpal arteries, like this whole mess in here, this is also getting blood from your radial artery as well as your ulnar artery, as well as your posterior and anterior interosseous arteries. They actually come back together and give blood supply to this dorsal carpal arch as well. So all things end up like ending in the hand when it comes to the upper limb arterial blood. Okay. So the branches that he listed for y'all, so radial recurrent was for the anastomosis around the elbow, and then your palmar carpal branch, your superficial palmar branch, your dorsal carpal branch, your princeps pollicis, radialis indicus, and deep palmar arch, we already talked about with the other picture. And then for your ulnar artery, so your ulnar artery for the anastomosis around the elbow, it gave off your anterior ulnar recurrent, your posterior ulnar recurrent, and your common interosseous artery. And remember, they're anastomosing with branches from your brachial artery for the anastomosis around the elbow. Versus the branches for your hand are your palmar carpal branch, your dorsal carpal branch, your superficial palmar arterial arch, and your deep palmar branch. Thankfully, these names are very descriptive and they're telling you exactly where the blood is going in the hand. Now, the clinical correlation that we use for this is the Allen test. So because your hand represents an anastomosis of the radial and the ulnar arteries, theoretically, if one is blocked, the other one would still be able to supply blood to the hand. So to test to see if there is a blockage, what you do is an Allen test. So you have the patient put their hand and their forearm on the table, and you would use your two thumbs along their wrist in their distal upper limb to feel for a pulse. So you're feeling for the ulnar artery and you're feeling for the radial artery. So you find that pulse, great, awesome. You're going to use one thumb to occlude one vessel. So for instance, using your right thumb, you press down on the radial artery of your patient and you see, does their palm stay pink? If their palm stays pink, since you're occluding the radial artery, you know, oh great, the ulnar artery is still giving blood supply to the hand. Awesome. You then switch to your other thumb, you occlude the ulnar artery, and you look at the hand. If the hand stays pink, you know that the radial artery is still giving blood supply to that hand. There is no occlusion in either vessel. If the palm ever goes pale, that tells you that whatever artery is not occluded, whatever artery you are not pressing on with your thumb, there is a blockage in that artery and you want to further investigate. Because that could be a sign that the patient has DVT, well, excuse me, not DVTs, because DVTs is in the leg and that's deep vein thrombosis. But anyway, they have some sort of occlusion in that artery and you want to investigate it further for possible like removal or like possible anticoagulation. Like that's a further discussion with vascular and beyond the scope of my knowledge. But it's basically telling you, are both of these arteries that are supposed to be giving blood to the hand actually giving blood to the hand, or is one of them occluded and then we have to refer this person out for further testing and further treatment? So that's what the Allen test is. Hold on, is that the Allen test? Well, this is the one that was the test that I learned. It's forcing the hand by making a tight fist. Yeah, this is it. This is the Allen test that I just described. They just have you make a tight fist to do it because when you make a tight fist, you force out the blood in your hand. But yeah, it's the whole like occlude one, does it pink up? Occlude the other, does it still pink up? Okay. So that's anastomosis of those two, anterior forearm. All right, so with the bit of time that we have left, I am going to switch gears because somebody had a specific question about what's the difference between a PIP versus a DIP, and that is a very specific hand question. So,
Can you repeat the question really quick?
oh, I'm sorry. What did you say?
You said what's the difference between what?
The PIP and the DIP, and I'm going to explain what I'm saying. So when I say PIP or DIP, it is a shorthand for these joints. So the proximal interphalangeal joint, interphalangeal, versus the distal interphalangeal joint. So PIP is proximal interphalangeal joint versus DIP is distal interphalangeal joint. So notice how there's a joint here that is distal, and it's in between your distal phalange with your middle phalange, versus there's a joint here that is more proximal, that's in between your proximal phalange and your middle phalange. It's literally just naming the joints. So this is your DIP versus this is your PIP. That's what they mean when they say that. Sometimes people will interchange it with, and I put it here, sometimes people will interchange it with just the phalanges themselves, because you have a distal, a middle, and proximal versus just a distal and proximal for your thumb. But specifically, when it's DIP versus PIP, excuse me, they're usually talking about the joints. And that's because when you get further in your studies, things that cause inflammation and wearing down of the DIP, the distal phalangeal, versus the proximal, the PIP, they can be different. So like osteoarthritis versus rheumatoid arthritis. One usually is more often in the distal versus the proximal. And I don't remember which is which. I think it's osteoarthritis in the distal, but don't quote me. And I think it's RA in the proximal, but I have to look them up. That's just one of those random facts that we memorized before taking an exam or a step exam. And it was like, okay, so that's a helpful thing to try and distinguish between OA and RA. But yeah, so this is your distal interphalangeal joint. That's your proximal interphalangeal joint, your DIP versus your PIP. So I just wanted to make sure I got to that because it's 11:55. Let's see. What else was in Dr. Lobo's slides? All right, it looks like these last couple of ones was just talking about venous blood supply and venipuncture. So since we only have like a couple minutes left, well, really we're done because it's 11:55. I'm actually going to not go over these and stop the recording. Like I said before, the recording from yesterday should be up in your class drive, and I will get this recording to your class rep as well. I'm going to be sticking around to do attendance. So please make sure if you have not already, please type your name in the chat. Otherwise, have a lovely Sunday. If anybody has any last minute questions, I am available to stick around for a little bit to answer last minute questions. I'm just gonna step off for a bit to like walk around and like move around my legs. But yeah, I'll be here for at least the next 15 minutes. If you have any other questions you wanna ask, just give me like 5 minutes.
Kristen, are you still there?
Yes, I'm still here, but can you give me like a minute or two?
Yeah, of course.
Hey, Chica, were you the one who was asking a question?
Yes, that was me. I have a quick question about the radial and the medial artery, or it might be on. But I noticed that on his slides, under radial artery and the ulnar artery, he has both the deep palmar arch and the superficial palmar arch. I'm mainly talking about the anastomosis between them. So is it safe to assume that the radial artery mainly supplies the superficial palmar arch and the ulnar does the deep palmar arch, or is it just both?
So you have to ask him that because I've gotten this question before and it is completely professor dependent.
Okay.
Yeah. Because the thing is that when you just look at the pictures, you can see that both of them are supplying it. But I've had it come up before where a professor has said, well, this arch is mainly from this artery and this arch is mainly from the other artery. Now is just like, okay.
And
So
was I right to say it's ulnar artery and radial artery, or is it medial?
ulnar artery and radial artery for the arches, yeah.
Okay, good.
Yeah.
Just making sure.
Let me look for that picture since you mentioned it. Oh, that's the muscles. You gotta scroll down to blood, Kristen. There. Yeah, from the pictures, if you were to guess, superficial looks like it's mainly ulnar and deep looks like it's mainly radial.
Oh, deep's radial. Okay.
Yeah, but this is me guessing from the pictures. Really, like, ask the professor what they want. For this
Okay.
particular one, ask them what they want.
Okay, perfect. Okay, that's my last question for. No, actually, I do have a question about. I know you said you like to draw, and we talked about this last week and how I like to do that too.
Mhm.
But I was wondering, how did you balance that with your other classwork?
Um, it was never like it was never an issue with me. What I ended up doing for my studying was I would take the time that I had and I broke it apart into sections. So doing anatomy for 2 hours and then doing micro for 2 hours and then doing ppm for like an hour, and that was 5 hours right there after I'd already been in lectures for, was it 8 hours? And I was one of those persons who, so I didn't actually do, oh sorry, I thought I stopped the recording. Oh,